Hello class. We're going to be starting a review of the stages of the normal swallowing process. We're going to take a close look at the events associated with each stage, as well as specific muscles and corresponding cranial nerves that we should pay attention to as we discuss the progress from the very beginning of the swallow all the way down to the point where the bolus enters the stomach. So let's go ahead then and begin. Sort of as a prelude, what I would like to do is recommend a book to you. This book is called Follow the Swallow. Great little title. And it goes in and out of print, so you might have to look for it, say, on Amazon. But if you find yourself working with patients or children with dysphagia, it functions almost like a flip book, showing you the progression of the bolus as you flip through the pages. And from the front, one way, it's a normal swallow. If you flip the book over from another way, it's an abnormal swallow. So it's just a great teaching tool. As I said, if you're going to be working with individuals who have a swallowing problem. Okay, let's go ahead and talk in general about the stages involved in swallowing. Now, as you can see, I have written here on this slide that there are 4 stages of deglutition or swallowing. So deglutition is just another word for swallowing. I have listed oral preparatory, the oral stage, the pharyngeal stage, and the esophageal stage. Now, in reality, as you can see at the bottom, the oral prep and the oral stages are often combined in reporting the results of an assessment, in describing a problem, and really for some people in thinking about the swallowing process. So because of that, you also have to be ready to think about swallowing or deglutition in terms of the 3 stages. That would be oral, pharyngeal, and esophageal. Let's begin with the oral preparatory stage. The oral preparatory stage is really a substage, as mentioned on the previous slide, for the first stage of swallowing, which is the oral phase. Now, in contrast to later stages of swallowing, the oral preparatory and other parts of oral phase activities are under control of cortex. In the case of the oral preparatory phase, it is the medial temporal lobe that controls a lot of the voluntary activities of this stage. Now, that's not to say that because it's voluntary, it is completely conscious. It is overly routinized, most of the oral preparatory and oral phase, and so because of that, we don't have conscious thought about each activity that occurs in the oral preparatory stage. The oral preparatory phase includes the important input of sensory information about the food that will be ingested. So this can be everything from visual stimuli to olfactory, auditory stimuli, kinesthetic. It's everything that goes into essentially having your body get ready to eat. And these kinds of cues, we will see later, are very important to highlight in some sense for individuals who have cognitive issues that prevent them from recognizing sensory input or the importance of sensory input. For the rest of us, looking and recognizing objects as food and delicious food, being able to identify and associate olfactory stimuli as part of the eating process, even the sounds that come from food preparation or pouring liquids can be useful in getting the apparatus ready to process food and participate in eating. Also, kinesthetic cues become important. So the sensation when the lip and the food item touch, the feel of the bolus when it enters the mouth in terms of texture and temperature, all of those are important aspects of the stimuli. It's interesting to note that there is differential preparation of food materials so that when something enters the mouth does something different, essentially, depending on the nature of the material. For example, with liquid that is presented into the oral cavity, the tongue typically cups around the bolus. Again, the bolus is the wad of material or the mouthful of food or the sip of the liquid. For puree, the tongue manipulates and holds the bolus, but there isn't any signal that tells the oral cavity and the oral structures that they need to get ready to masticate or to prepare and shred and grind the material. If the material is a solid, essentially the body gets signals that tell it to prepare to chew. A few more things I wanted to say about mastication. First, mastication is a relatively complex act in the adult human. The upper and the lower teeth crush and tear the bolus, it's true, but it's more differentiated than a simple up and down kind of chewing motion. In fact, we associate that just opening and closing, up and down kind of chewing with infants who aren't very skilled yet at chewing. We also need to take note that the jaw moves in a lateral and rotary fashion to help manipulate the bolus. So when we're chewing, if we open our mouth, the food falls sort of in a medial position and medial aspect of the oral cavity, but then it's pushed back onto the teeth as the jaw rotates a little bit and opens and then closes. We know that during mastication saliva is mixed with the bolus by the tongue, and also it gets thoroughly mixed with solids that are chewed during that process. Now, during the oral preparatory phase, the posterior aspect of the oral cavity is closed. This is to keep the bolus inside the oral cavity until it's ready to be swallowed. The gate, as it were, in the posterior aspect of the oral cavity is the soft palate and the back of the tongue, and they have made contact essentially to form a barrier for the bolus. In the anterior aspect, the lips have closed and prevent bolus material from escaping from the oral cavity in that regard. You can imagine if someone has a structural abnormality or they have innervation difficulties with the lips, that they would have a significant problem in the oral preparatory phase. Finally, the larynx is at rest during the oral preparatory phase. We should not see any laryngeal activity or movement during the stage. It's simply not time to prepare for the actual act of swallowing. Now we're going to be talking about the oral stage. And again, if you are a person who thinks that there's only 3 stages of swallowing, then you're going to include many of those activities that I just discussed under oral preparatory as part of the oral stage. So for the 3-stage people, the oral stage is really pretty big and complex in terms of the activities that are contained in that stage. So in the oral stage, we already have the bolus that is in the mouth. Chewing has already taken place if you believe in the oral preparatory phase. And the tongue tip and the sides are elevated, essentially forming a groove, or some people say a trough, for the bolus, such that there is a pathway for the bolus to exit the oral cavity in the posterior aspect. The tongue then begins to press the bolus up against the hard palate. So the tongue tip, which may have already been right behind the alveolar process, pushes and scrapes and squishes along the length of the hard palate from anterior to posterior. And again, we see differential activity of the structures that are used in food preparation depending on the viscosity or the nature of the material. So for a bolus that is very dense, a bolus that is sticky and hard to control, more tongue pressure will be used. At the end of the oral phase, the larynx begins to elevate. This is the signal that we have almost reached the beginning of the next phase, the pharyngeal stage. In fact, when the bolus clears the oral cavity, or it passes by the ramus of the mandible, then we can say that triggers or starts the pharyngeal phase. Now, we should talk briefly about the duration of certain stages of swallowing. You can imagine that the oral preparatory phase is going to be as long as it needs to be to appropriately prepare the bolus. So if it is involves mastication of a tough substance, or if it requires any kind of manipulation of the tongue to deal with both the liquid and the solid material that might be in a soup, then that oral preparatory or oral stage might take a considerable amount of time. However, the oral stage per se, that is, the time it takes from the beginning of the moment that the tongue starts scraping back along the length of the hard palate until the bolus passes the ramus of the mandible, that passage of the bolus takes approximately 1 to 1.5 seconds. It is an incredibly quick act. We are still talking about voluntary activities. I don't necessarily, again, mean conscious, but certainly voluntary in that you can start and stop the activities at will. Let's talk a little bit now about the muscles, their action, and the innervation of the muscles for specific activities that we have in the oral preparatory or just the oral stage. For example, we're looking at overall the muscles that might help to provide an anterior seal for the bolus inside the oral cavity. And this is very important, especially as you get larger boluses, or if you are sucking on a straw. So the muscles that come into play at this stage, for example, are the orbicularis oris and the incisivus labii. The innervation for these muscles that are important for bolus containment is from cranial nerve 7. Another action that might be important is bolus control, not just in terms of anterior containment. These muscles that we're going to be talking about are innervated by cranial nerves 7 and 12, and this list over here on the left should look familiar to you. The buccinator and the risorius to keep lip tension appropriate, the genioglossus and the intrinsic muscles of the tongue to create specific tongue shapes, such as anterior depression of the tongue tip and then the elevation eventually of the tongue tip, and also creating that midline depression. During mastication, the muscles in use are primarily those innervated by cranial nerve 5. So these would include the masseter, the medial pterygoid, and the temporalis. Those are the mandibular elevators that are so helpful in mastication. The muscles that are responsible for lowering the mandible would be the muscles like the lateral pterygoid, the anterior belly of the digastric, the geniohyoid, and the mylohyoid. Innervation for these muscles comes from cranial nerve 5 and 12. Mastication also requires coordination of lips with the jaw, with the tongue, and we have a group of muscles here that correspond to innervation by cranial nerve 7. This would be a good time to talk about what aspects of this kind of knowledge you would need to know for an exam. So to discuss this point, I'm going to go backwards in the slides for just a moment. I'm going to use mastication, mandibular elevation as my example. So I would expect you to know that the elevation of the mandible is primarily a cranial nerve 5 activity, and I would expect you to be familiar enough with the muscles of mastication here that you could recognize, if I gave a multiple choice question, which of the following is not a mandibular elevator, and I gave you a choice of the masseter and the medial pterygoid, the temporalis, and the frontalis, that you would be able to recognize the frontalis is not a mandibular elevator. We're still in the oral stage. I did want to talk a little bit more, again, to compare and contrast the 3 with the 4 stage model. So we're going to introduce at this point a phrase called the oral transit phase or the oral transit subphase. If you are a 4-stage swallowing advocate, you will be talking about the oral preparatory, then the oral, including oral transit, pharyngeal, and esophageal. If you are a 3-stage advocate, you will include oral preparatory, oral, and oral transit all as just oral stage. So I wanted to go back over a few more points just to make sure that we understand what happens as the bolus begins to move. Now, you recall, I'm sure, that I mentioned that the tongue moves longitudinally, so anteriorly to posteriorly along the hard palate to propel the bolus towards the posterior aspect of the oral cavity. We consider that the beginning of transit for the bolus. But the tongue tip is not the only aspect of the structures that are moving. The tongue tip and the sides are both elevated in order to sort of scrape the bolus to the posterior and not lose pieces of bolus in the lateral dimension. At this point, the soft palate, which has been in a relaxed, non-innervated position, begins to elevate to form closure of the oral cavity from the nasal cavity, and also in the process of elevating, it begins to create an aperture, an opening through which the bolus is going to slide. At the same time, the tongue base drops so that the opening or the aperture becomes even bigger and is sort of the logical path of least resistance. I won't talk too much about the pressures that are involved and the pressure changes that occur during oral phase activities, but I will say again that there's a pressure differential exerted by the tongue as there's a change in the characteristics of the bolus. And as I mentioned earlier, the oral phase is over when the bolus reaches the ramus of the mandible. This is a very dramatic or well-viewed, easily seen landmark when you're watching a video, because you can see the bolus, which has material in it that makes it visible to those viewing the video, approach and then pass by the ramus of the mandible, and you know then that's the end of the oral phase. Let's discuss at this point a question that is very important when evaluating someone's video swallow. The question is bolus spillage, and those letters stand for within functional limits. In the olden days, we used to talk about things as being normal or abnormal. But in more recent days, we have recognized that there is really a range of abilities that constitutes normal, and that may not be a very useful designation. Instead, often in medicine and in allied health professions, you see the abbreviation WFL, within functional limits, meaning it's pretty close to where it should be for that patient and their age and their condition. All right, so back to our question, is bolus spillage within functional limits? Many people say yes. It's okay, even normal, whatever that is, to have some spillage, even to the point where there's material that falls over the base of the tongue and into the vallecula. Now, you're saying, I'm sure, to yourself, isn't that what happens once the port opens as a result of the soft palate elevating? Yes, but even in normal individuals, sometimes that seal is not airtight, and we see material spilling somewhat prematurely, and you'll hear the phrase premature spillage. So if you are a little bit more liberal in this regard, then you might be someone who says, a little premature spillage is not the end of the world. It's pretty normal. And having material fall into the vallecula, even those little pockets near the root of the epiglottis, that's within functional limits. Other clinicians and professionals say, no, there should never be premature spillage of bolus material. In other words, no spillage at all until it's time for the pharyngeal phase of the swallow to begin. The reasoning behind this second position is that if there is spillage before the pharynx and the larynx are essentially ready for the bolus to pass by, that exposes the person to penetration or aspiration, terms that we'll talk about soon, and thus is not something that should be considered part of normal functionality. I'm a pretty common sense clinician. I'm somewhere in between the two. So I don't have a hard and fast rule per se, but I do like to look at the overall health and age of the individual that I am looking at. If I have an otherwise healthy 83-year-old who maybe has a little bit of premature spillage of, let's say, solid into the vallecula, before the initiation of the next phase, the pharyngeal phase, but there's no entering of that material into the airway and no sense that at all that the swallow is otherwise abnormal. If those things are all true, I'm much less likely to be concerned about spillage into the vallecula prematurely. Okay, one more word about timing issues. Recall that the movement of the bolus, we said earlier, it was about 1 to 1.5 seconds, but it is in fact a little bit longer for people who are over the age of 60. Not much, 3/10 of a second, but just a little bit longer. So you can imagine if that transit time is a little longer if you're older, that would give particles a little bit of time to prematurely spill into the pharynx while the oral cavity is still being stripped of the bolus. Okay, a few more words about charts. This one happens to be about propulsion of the bolus. Again, the usual suspects are the cranial nerves involved, 7, 5, and 12. These have to do with propulsion from the point of even the lips pressing together and essentially creating additional force at the beginning of the propulsion of the bolus. The importance of the buccinator in squishing and tensing the lateral aspects of the oral cavity, and as discussed earlier, certain muscles such as the intrinsic lingual muscles then are important for making that groove or trough in the middle of the tongue. So what would I know from this stage? I would know that muscles innervated by 7 and 5 and 12 are important for bolus propulsion at the level of the oral cavity, and certainly thinking about all of the muscles in that region, everything from very anterior muscles to lateral muscles to sort of floor of the chamber muscles. I wanted to mention that it's good to be familiar with some of the terms that I've mentioned and some I haven't mentioned yet. For example, it's good to remember that there are sulci or indentations in the oral cavity that in many instances can pocket material that is being processed in the oral cavity. So in your own case, think about what it's like to chew a peanut butter sandwich, for example. While a lot of the sticky residue in eating peanut butter seems to be on the roof of the mouth, it's also possible to have material such as the bread and the peanut butter stuck in between your lip and the osseous structure of your jaw. Those would be the labial sulci. Or to have material stuck in the buccal sulci, and the term buccal refers to cheeks. So these would be the sulci that are between the line of dentition and then the muscles that are involved in shaping the buccal cavities. In addition to the sulci, we have the fascial arches or the pillars. These would be the two bands of tissue around the tonsils. And these are tissues that in fact can, when touched, also trigger a gag reflex. The ramus of the mandible is important because, as I mentioned, it's an important landmark in determining the end of the oral phase and the beginning of the pharyngeal phase of the swallow. A word about sensation. It seems that most of our emphasis in the dysphagia examination and in thinking about swallowing is on motor control. But I can't emphasize enough that sensory information is very important to the swallowing process. We saw this first in the oral preparatory phase, where we talked about the importance of sensory stimuli in preparing the oral cavity to receive food. In this instance, I wanted to talk about the sensations that act as important feedback mechanisms that are within the oral cavity itself. So that would be anterior 2/3 of the tongue, at the tongue and the lips and the cheek, etc. FOM stands for the front of the mouth. Likewise, the posterior 1/3 of the tongue is especially important. You can imagine that the sensory information that results when it loses its seal from the velum, as the velum elevates, and as bolus material is passing by, that information be really relevant and important to triggering the pharyngeal phase. A little bit about taste. Again, taste is sensory information, so the tongue is busy processing, sending and receiving information about all aspects of the bolus. So the size of the bolus, the temperature of the bolus, but also the importance of sensations about taste. This is very important in safe eating, right? So that if something doesn't feel good or taste good, it's a fairly primitive method for deciding that perhaps it's not food. Cranial nerves 7 and 9 are important in sending essentially the taste sensations to the brain for processing. We are almost ready to talk about the pharyngeal phase. The pharyngeal phase is important for many, many reasons, but it marks not only the passage of the bolus, but an entirely different type of acts in the swallowing process, so that no longer at this phase are we as concerned with voluntary activities, but we are concerned with the involuntary activities that are mediated by specific areas in the brain. I did want to mention that as the pharyngeal phase begins, other activities involving the pharynx, such as chewing and breathing and coughing and vomiting, all of those other activities are inhibited. Breathing in particular is something that will become important later on, because it's important to note that swallowing is this apneic event. And apneic is the adjective. You've heard, I'm sure, the noun apnea before, meaning not breathing. So swallowing is an apneic event where you're not able to breathe. For most of us, this is not a problem. For individuals who are sick and hospitalized and already have low oxygenation of their blood, this